Continuing with this, I would like to call Sudipta Paja for share his PPT. The topic is about the anatomy of large intestine.
Good afternoon, everyone. Respected sir and madam. I am student of DIT last year, CNC. Today I discussing about the anatomy of large intestine, which is the last part of the GI tract. What is large intestine? Large intestine is the long tube-like organ, and it is also called a large bowel. It begins from the ileocecal valve of the cecum, and it ends at the anal canal. It has divided into 8 parts. The first part is the cecum, and the second part is the ascending colon, and the third part is transverse colon, then the descending colon, sigmoid colon, rectum, and anal canal. And appendix is the vestigial organ. The total length of the large intestine is 1.5 meter or 150 centimeter. Cecum is about 6 centimeter. Appendix is about 2 centimeter to 20 centimeter. Ascending colon 15 centimeter. Transverse colon is 50 centimeter. Descending colon 25 centimeter. Sigmoid colon is 40 centimeter, and the rectum with anal canal is about 15 centimeter. There are 3 cardinal features in the large intestine. The first of all is tinea coli. These are the 3 thickened bands of the longitudinal muscle. It is totally absent in the rectum and anal canal. Then the second is appendices hemiploica. These are the peritoneum covered projection from the wall of the colon and filled with adipose tissue. The next one is frustration. These are the circulation in the wall of the colon with incomplete septa, partly due to the tinea coli. Then the first part of the large intestine is cecum. Cecum is a blind sac which hosts some symbiotic organism, and it is the first part of the large intestine, located in the right iliac fossa. It begins from the ileocecal valve, and it continues distally with ascending colon. It has about 6 centimeter in length. It is a large shaped like a coma. Then its relation. Anteriorly relation is the anterior abdominal wall. Posteriorly relation is iliacus and cutaneous nerve. Laterally the paracolic gutter, and medially terminal ileum and base of appendix. Then the vermiform appendix. It is a narrow own tube, and it is a vestigial organ in humans, located in the right iliac fossa, and its length is 2 centimeter to 20 centimeter. Then its position. First of all, the retrobolic position. It is about the 12 o'clock position, and the second is perineal. It also the 3 o'clock position. Posterior position is also it is also 3 o'clock position. Then the pelvic position is 4 o'clock position. Midline position is 8 o'clock position, and the parapet position is also 11 o'clock position. The second part of the large intestine is ascending colon. It begins from the cecum and at the transtubercular plane, and it extends ends to the right coliflexor, and its length is about 15 centimeter. Then its relation. Anteriorly relation is the anterior abdominal wall and greater omentum. The posteriorly relation is the iliolumbar ligament and iliohypogastric. Laterally the paracolic gutter, and medially the medial paracolic gutter. Then the third part is large intestine is transverse colon. Transverse colon is a segment and the largest part of the large intestine. It begins from the right coliflexor and ends to the left coliflexor. Its length has 15 centimeter. Its relation. above liver and gallbladder, below the small intestine. Anteriorly written is the greater omentum, and posteriorly second and third and fourth part of the duodenum and the head of pancreas. Then the fourth part of large intestine is descending colon. It is the part of colon and smaller in calibre than the ascending colon. It begins from the left colic trachea and it ends to the pelvic inlet. It has 25 centimeter in length. Relation. Anteriorly relation is the anterior abdominal wall. Posteriorly relation is transverse abdominis. Laterally the paracolic gutter and medially medial paracolic gutter. Then the sigmoid colon. Sigmoid colon is the terminal portion of the large intestine. It begins from the descending colon. It ends to the rectum, which is about 4 centimeter in length. Then its relation. Superiorly relation is coils of ileum. Inferiorly bladder in male, uterus and bladder in female. Posteriorly sacral plexus, uterar, left internal iliac vessel. Laterally left external iliac vessel and lateral pelvic wall. Then the rectum. It is the part of large intestine between the pelvic colon and anal canal. It has none of the three cardinal features. It is located in the pelvic surface of the sacrum and coccyx. It begins from the pelvic colon at the upper border of S3 vertebra. It ends at anal canal. Its length has 12 centimeters. Relation. Anteriorly relation is in front of upper 2/3 is peritoneal part and in front of lower 1/3 is non-peritoneal part. Posteriorly, the pelvic surface of third and fourth pieces of sacrum, coccygeal plexus and superior rectal vessels. Anal canal. It is the large portion of the large gut without any cardinal feature and it is the non-peritoneal location. It lies in the anal triangle between the two istiorectal fossa. It begins from the anorectal plexus and it ends at anal verge. It has about 3.8 centimeter in length. Then its relation. Anteriorly relation is structure at the base of urogenital triangle. Posteriorly the anococcygeal and rep and body, and at a side levator ani and sphincter ani externus separate the anal canal from the istiorectal pad of fat. Then its arterial supply in the cecum. Anterior cecal artery and appendicular artery is supplied on cecum, which is the branch of ileocecal artery. Appendicular artery is the branch of ileocecal artery, which is supplied on base of appendix. Then ascending colon is the right colic artery, which is the branch of superior mesenteric artery and supplied on ascending colon. Then the transverse colon. Right colic arteries and left colic arteries, also the branch of superior mesenteric artery and inferior mesenteric artery, supplied on the right colic artery supply on right 2/3 of midgut and left colic arteries supplied on left 1/3 of midgut. Descending colon. Left colic artery, which is branch of inferior mesenteric artery, supplied on descending colon. Sigmoid colon. Sigmoid artery, which is the branch of inferior mesenteric artery, supplied on sigmoid colon, and rectum with anal canal is superior rectal artery, which is also inferior mesenteric artery, upper and lower part of the rectum and lower part of anus. This is the arterial supply picture. And then venous drainage of large intestine. In the cecum, right colic veins, ileocolic veins and medial colic veins are raised into the superior mesenteric vein. Then appendix, appendicular vein drains into the ileocolic veins. right, then the ascending colon, right colic vein and ileocolic vein is also drains into the superior mesenteric vein, transverse colon. Middle colic vein and right colic vein and left colic vein are drains into the superior mesenteric vein and inferior mesenteric vein. Descending colon. Left colic vein is drained into the inferior mesenteric vein, sigmoid colon. Sigmoid vein and left colic vein is drained into the inferior mesenteric vein. Then the rectum. Inferior mesenteric vein and inferior rectal vein it drains into the portal vein and internal pudendal vein. And anal canal is inferior rectal vein drains into the portal vein and pudendal vein also. Then its lymphatic drainage. Common iliac artery, common iliac lymph nodes are drains into the common iliac artery. Internal iliac lymph nodes are drains into internal iliac artery, and lymph nodes of anal canal is drains into the medial group or superficial inguinal lymph nodes. Then the nerve supply of large intestine. We all know there two types of nerve. First, sympathetic or parasympathetic nerve supply and the large intestine. Midgut derivatives or midgut areas. For midgut areas, the superior sympathetic and parasympathetic nerves are branch of superior mesenteric artery. Is distributed in the cecum, appendix, ascending colon, and the right 2/3 of transverse colon. For the hindgut areas, two types of vein, two types of nerves, sympathetic or parasympathetic, which is also branch of inferior mesenteric artery and distributed on left 1/3 of the transverse colon and descending colon, sigmoid colon, rectum, and anal canal. Now it is the anatomy of the large intestine is. Large intestine can be directly viewed by a procedure that is called colonoscopy. Next, diverticulum is a small evacuation of mucous membrane of colon at the entry point of the arteries. Its inflammation is called diverticulitis. Inflammation of appendix is known as appendicitis. Then the investigation of large intestine is straight X-ray abdomen, barium meal follow through, distal cologram, CCT abdomen, MRI pelvis for rectum, and the colonoscopy. Thank you for all the respected sir and madam sharing my presentation. Thank you.
Thank you, Sudipto, for such a wonderful presentation. Thanks to all from Radiotherapy Department for helping and participating in our CME. And a special thanks to our sponsor, GE Healthcare.
After Shudipto, I asked my batchmate Akash Chakraborty for explaining his PPT over investigation of large intestine.
Good morning, sir. Good morning, madam. Good morning, everyone. Good afternoon, everyone. I am Akash Chakraborty, intern of DAT, CNCI. Today I am talking about the investigation of the last part of our digestive system, investigation of large bowel. So before beginning, let us quick review about the anatomy of our large bowel. So large bowel is mainly divided into 9 parts: appendix, cecum, ascending colon, hepatic flexure, transverse colon, descending splenic flexure, descending colon, sigmoid colon, and rectum. So there are many types of investigation done in large intestine. The investigations are straight X-ray abdomen, USG whole abdomen, barium meal follow through for IC region, barium enema, distal cologram, CT abdomen with virtual colonoscopy, MRI pelvis, and colonoscopy. So before going to the main point, let us talk about the investigation of choice. for large intestine. So colonoscopy is the investigation of choice for large bowel because it can be useful for diagnostic purpose as well as therapeutic purpose. Biopsy can be taken and any types of strictures and diverticulum must be removed. So let's come to main point. Barium will today I will describe the three main barium related investigation for large bowel. Barium will follow through for IC region, barium enema, and distal cologram. Let's start with barium will follow through for IC region. So it is the investigation of ileocecal junction using barium suspension as a contrast medium. The indications are pain in right iliac fossa, weight loss, chronic abdominal pain, gastrointestinal hemorrhage, abdominal mass, and partial obstruction. The contraindications are complete large bowel obstruction, history of aspiration, recent biopsy from GI tract. Now patient preparation. Give the advice to the patient to take a suspension of barium meal approx 300 ml 4 hours before to the examination, and to increase the peristaltic movement of the colon, buscopan or glucagon injection should be given. The patient is advised not to smoke on the day of the examination as it is increased gastric mobility. Now coming to the technique. First, a control film should be taken to assess whether barium is reached up to IC region or not. Then an abdomen supine, and next view is taken with compression at the right iliac fossa to open the collis of small bowel. Lastly, oblique view is taken. And a prone film is taken if IC region is not visualized properly at episupine. That is the special technique. The aftercare. The patient should be warned that their bowel motion should be wide for a few days, and the patient should be advised to drink adequate volume of water to avoid barium infection. The complications are leakage of barium from an unsuspected perforation, aspiration, barium appendicitis with barium impact in the appendix. Here we can see some abnormalities caught on in this investigation. First, normalized region, then deformed cecum with obvious IC angle, then multiple strictures, then close filling of cecum, dilated terminal of ileum, picture history of right hemicolectomy, and last ileocecal TB. Now move on to the second investigation, large bowel barium enema. So it is the investigation of large bowel by rectal administration of barium suspension. So the indications are history of parrectal bleeding, partial obstruction, mass in colon, rectovaginal fistula, and ulcerative colitis. The contraindications are toxic megacolon. Here, CT is the radiological investigation of choice. Abscess in anus, acute infection, history of recent rectal or colonic biopsy. Patient preparation. To remove the bowel gas and feces, the patient should take 2 Dalculus tablet and 2 Pascal N tablets before night of the examination after dinner. Low residual diet for 3 days prior of the examination, and fluid only on the day of the examination. Technique for double contrast method. The patient lies supine position and control film should be taken. Then the patient lies on their left side and the catheter is inserted gently into the rectum. After insert the catheter, the barium fields are raised into high to give the maximum gravitation effect. The fluoroscopy is required to check the progress of the barium. The air is gently pumped into the bowel to produce a double contrast effect, and the procedure is carried out to fill up the cecum with the barium and air. Now look at the fields are taken in various projections. First, pelvis lateral for rectosigmoid junction and for perirectal fat plane. Then episupine for abdomen for whole large bowel. Third film is left anterior oblique to open splenic flexures, then right anterior oblique for to open hepatic flexures, and last right lateral of the rectum. But the film and sequence can be modified according to the patient. And here we can see some views of barium enema procedure. First, single contrast barium enema, then left lateral decubitus, then left anterior oblique for splenic flexures, right lateral decubitus. Film is the double contrast barium enema, and last angle cone for 30 to 35 degrees. The aftercare, the patient should be warned that their bowel motion should be wide for a few days. After the examination, they may eat normally and should drink extra fluid to avoid barium infection. Itching sensation should be around the anus may be developed to barium enema catheter. Avil injection is required in this case. The complications are perforation of barium, side effect of pharmacological agent use, intramural barium, and venous intervention. So here we can see some abnormalities got in this procedure. First, ulcer in spongic disease, then single adenomas for colonic polyp, then barium filled colon usually carcinoma, colonic lesion, acute attack of ulcerative colitis, and then polypoid adenocarcinoma. And finally, we are go to the final investigation, distal cologram. So, distal cologram is a radiological contrast study of post-operative case to visualize the distal part of colon with the help of barium sulfate solution. There is no definite period for distal cologram after operation. The indications are to demonstrate proximal colon following recession of the barium before closing colostomy. In post-operative case of RTA, when leakage chances are maximum, or other abdominal operation. Technique: the patient lies supine on X-ray table and control film should be taken. Proximal part of colon can be identified easily to see the passage of stool. Now cannulate colostomy with a rubber catheter and generally to prevent retrograde flow. The barium solution will introduce with the help of 50 cc syringe. The whole length of distal part of the colon up to the anal canal should be visualized in the AP and lateral views, and if required, both right and left oblique views should be taken. The only contraindication is any leakage of barium inside the abdomen. Finally, there is a picture of barium in distal cologram. And finally, I will thank you all my sir and madam to give me some golden opportunity. Thank you.
Thank you so much, Akash.
At the end, we call Shreyashri Bhandari from DRT for describing her PPT on treatment of
Good afternoon, everyone. Myself, Shreyashri Bhandari, DRT student of Chittyaranjan National Cancer Institute. Thank you for giving me the opportunity to present my topic, carcinoma in rectal cancer. So, what do we basically mean by the rectum cancer? When the cancer cell develops in our rectum, it is the part of our large intestine, then it is called the rectal cancer. The rectum is the chamber that is located between our colon and our anus. Next, we know nowadays treatment techniques are improving, so we can see that the survival rate for the rectal cancer is also increasing. Here you can see the overall 5 years of survival rate is 63%, and the rectal cancer is mainly shown in the men than in women. So how can we identify the rectal cancer? There are signs and symptoms. Let's see. It is blood in your stool, low hemoglobin count, loss of weight, changes in bowel pattern, and the abdominal pain. After identifying the rectum cancer, we go for the diagnosis with the help of some tests like rectoscopy, biopsy, CT scan, MRI, and the PET scan. After diagnosing, we go for the choosing of the treatment modalities. Either it can be surgery, then chemotherapy, and then finally it comes the radiotherapy. So what we basically aim in radiotherapy? is to kill the cancer cell by giving a maximum dose to the tumor and minimal dose to the normal surrounding tissue. And the target we delineate like primary tumor, tumor bed, adjacent lymph nodes, and the P-sacral regions. Next, we go for the radiotherapy techniques we follow. As you can see in my PPT, the treatment techniques are divided into three parts: either EBRT, external beam radiotherapy, brachytherapy, and the IORT, intraoperative radiotherapy. Under EBRT, it is again divided into two parts: conventional and conformal. In conventional, we do follow 2D techniques like APPS fields, and also sometimes we do 4-field box technique. Under conformal, we do IMRT, VMAT, 3D and IGFT. So let me explain about the EBRT, external beam radiotherapy. Actually, in this method, what we do, we give a high energy X-ray to the patient tumor from the outside of the body, and it is done by the mainly two therapy. That is the intensity modulated radiation therapy IMRT, which deliver the targeted dose of radiation in a pattern to match the shape of the tumor. Intensity modulated radiation therapy uses sophisticated software and 3D images from CT scan to target tumors with greater precision. Next, we come for the IGRT, that is the image guided radiotherapy, whether we take the images before or during the radiation delivery to guide the treatment. Then we come for our to follow the radiation therapy in the rectal cancer. We follow some protocols like patients should be aligned either in supine or prone position. We ensure that the bladder is full or not. Then backlog is used as an immobilization device. Then ankle rest and knee rest is also used for positioning. And the procedure for the XBI we do, we import the CT image and then we select the PTV, GTV and CTV contouring. You can see the CT images in the left hand side, and after import on XBI, CT images. These are both the CT images. Nextly, in this picture you can see the bladder is marked, then CTV, clinical target volume, GTV, gross tumor volume, and the PTV. And the PTV is the planning target volume. Generally, we treat the patient for that. PTV is the volume generally we used. After that, we walk to the treatment room for aligning the patient and match the laser to the CT ISO. After that, we shape the couch according to the setup reference. Then we check XBI. In the image, ma'am, you can see that we do the matching of the anatomical structure or like pelvic girdle, femoral head, femur bone, and with the CT reference image, and also match the bony landmark. And here you can see the sheet is also provided. Then we strictly match the GTV, CTV and PTV with the reference to the CT contouring so that no tumor can be left untreated. Finally, shift is applied and mounted on the patient body. Then for conventional treatment, we maintain some field borders. Let's see. For the posterior and anterior field, the upper border is from the lower rectum S1 to S2. Upper rectum is from L5 to S1. Lower border, it is 3 cm below initial tumor volume or inferior obturator foramen. It is extending from the top sacrum to 5 cm below primary tumor bed. Laterally, it covers 1.5 cm outside lateral pelvis to include the pelvic side wall and internal iliac nodes. Then partially it covers the pre-sacral lymph nodes and the sacral hollows are covered anteriorly with adequate margin. For the lateral fields, the upper border we cover is the lower rectum for S1 to S2. Upper rectum is from L5 to S1. Lower border 3 cm below initial tumor volume or inferior obturator foramen. Partially it covers 2 cm behind the anterior bony circle margin. anteriorly 1 centimeter anterior to the promontory of the sacrum, which may vary according to the anatomy of the patient and the location of the tumor. The modification device we use like block on APPF field. Then the dose prescribed for the conventional treatment is 50 Gay in 25 fraction over 5 weeks. Then we come for the palliative treatment. This treatment is generally given to the patient to relieve the patient from the pain. Here we maintain the fields border and margin. The upper border is from low, for the low rectum is from S1 to S2. Upper rectum is from L5 to S1 and the lower border 4 centimeter below the lower end of the tumor or at the margin, and the laterally it covers the pelvic ring. Dose prescription for the palliative treatment is 30 Gay in 3 fraction over 2 weeks. So after giving a treatment to the patient, we came here in my last slide about the challenges we face like bowel, less bladder, gut infiltration, patient alignment, intrafractional patient movement, and the rectal gut. So I came to the last of my slide. It's about the morbidity and the patient care which we have for the radiation therapy. Irradiation of the pelvic can lead to the acute side effects such as cystitis, proctitis, ileus, or epidermitis, which may require a symptomatic treatment. Skin reaction in the sacral and the perineal region is common. Exposure to air and keeping skin dry. 1% of hydrocortisone cream reduces the erythema, that is the redness of the skin, and the irradiation. Also, low residual diet and diarrhea is one of the most common diseases for the rectal cancer patient, where it is to be needed to be treated. So, if it is severe, interrupt treatments or residue dose for the fraction. Thank you, ma'am. Thank you, sir, for listening to me.
Thank you so much, Shruti.
Next, we welcome Jeba Nasri to share her PPT about radiological investigation of small intestine.
Hello, good afternoon, everyone. Myself, Jeva Nasrin. I am intern of DRT of this hospital, Chittyaranjan National Cancer Institute. Today is my topic over investigations of small intestine along with extrahepatic biliary apparatus. What are the investigations of small intestine and extrahepatic biliary apparatus? Here is the list of this. First one is straight X-ray abdomen, USG upper abdomen, barium stomach and duodenum, small bowel enema, CT cholangiogram, CT enterography, MR enterography, ERCP, MRCP. Now, as my junior Arghun Mondal has already spoken up to about small bowel follow through, so I am starting with CT enterography. It is one of the most impactful examination to rule out any disease for small bowel enema, for small intestine. And CT enterography, it is a special procedure to produce detailed images of small intestine and structures within the abdomen and pelvis. It is better able to visualize the entire bowel wall with mannitol mixed water. 200 ml of mannitol is mixed with 1300 ml of water to make 1.5 liter of solution. It is used as endoluminal contrast media that produces significantly better bowel distension and visibility of mural features with improved image quality when compared to other small intestine imaging procedures. Now, what are the indications to doing this examination? If there is any small bowel inflammation, and to rule out any intestinal bleeding, if there is any indications for bowel obstruction, Crohn's disease, and to determine its location and severity and unexpected complications. And what are the patient preparations? Patient should keep in fasting for 4 hours, and patient also brings their urea creatinine report, as though we need to give them IV contrast. And in the patient preparation arena, patients are also encouraged to drink up to 1.5 liter of oral contrast, that is mannitol mixed water, at a steady rate 150 ml in every 5 minutes over 45 minutes. Now, what is the technique? After having the oral contact, then immediately after 45 minutes, the patient will be transferred to the CT scan table. Then a scout is taken, that is up to diaphragm to symphysis pubis, and then a plain scan will be done, and a dual phase of abdomen CT is done after giving the IV contrast, and we'll take 2 scans at 35 seconds and 1 at 70 seconds. And here is an image of CT angiography we can see. Now one more examination for the small intestine is MR angiography. It is similar to CT angiography, but it does not use any ionizing radiation, that uses the magnetic fields and radio waves to produce detailed images of small intestine. Now what are the advantages of CT angiography over MR angiography? First one, CT angiography images frequently provide greater diagnostic confidence for exclusion both small bowel and extraluminal pathology. Second one, CT has superior spatial resolution, and it is being first single breath hold examination. It facilitates luminal navigation. CT is also cheaper and more valuable than MRI angiography, and patients may have benefit from shorter examination time and avoid MRI associated claustrophobia. And there is also advantages of MRI over CT angiography. First one is MR has superior contrast resolution, and it demonstrates fistula button better than CT. And we use gadolinium based contrast media in MRI, that is more safer that we use in CT angiography, that is iodinated contrast media, and it is also free from radiation. That is one more advantage of MRI angiography. Now we may come in summary that CT angiography is a valuable and complementary addition to MRI angiography and capsule endoscopy in the diagnostic armamentarium of small bowel disorders. Wide availability of MDCT and examination efficiency with good patient tolerance will ensure a significant role for CT angiography, but this must be tempered with careful monitoring of the cumulative radiation dose. Now my second part is about extrahepatic biliary apparatus. There is main examination, but today I am starting with the TT cholangiography. This examination is done 7 to 10 days after operation before T-tube is finally removed. The purpose of the examination is to assess whether any retained calculi are present in the biliary system and to see the patency of common bile duct. The drainage T-tube is removed. Before the drainage T-tube is removed. And what are the indications for doing this examination? First one, to exclude biliary tract calculi when operative cholangiography was not performed or the result of the surgery are not satisfactory or suspected. And second one is if there is hemorrhage from the T-tube. Third one is if there is poor or absent drainage of bile from the T-tube after the surgery, and also to assessment of biliary leaks following the biliary surgery. Now what are the contrast media used in this? First of all, we may use HOCM, that is high osmolar contrast media, or LOCM, low osmolar contrast media, 15 milligram of iodine, which may be 10 to 20 ml of urographin. But we should keep in note that low density contrast media is used to avoid the obstruct in the calculus. And what is the patient preparation? Patients should not take any heavy food before 3 to 4 hours of this examination. Now here we can see an image of the T-tube, and we are going through the procedure. The drainage tube is sleeved off with artery forceps and contrast inject directly into the tube. We should care must be taken not to inject bubbles as they can mimic calculi. The procedure is monitored under fluoroscopy, so the entire biliary tree is filled and evaluated. Radiographs are taken at appropriate times. It is imperative to obtain adequate views of the common bile duct. The clamp is released at the end of the examination. And here we can see an image how this looks. This is the drainage bag after OT. Here is a bandage incision. There is common bile duct. Now what are the filmings are taken? One AP position exposure is taken, and oblique view, and an lateral. This is an image of the radiographic CT cholangiograph. Now one more examination for the biliary tree, that is the ERCP, endoscopic retrograde cholangiopancreatography. In this procedure, the dye is injected into the common bile duct and the pancreatic duct through a catheter that is pulsed down an endoscope. The endoscope, that is a thin, flexible, light-end tube that is gently pulsed down your throat and through your stomach until it reaches the duodenum. Here we can see that endoscope is passing through the stomach up to the duodenum. After reaching the duodenum, dye is injected through a catheter into the pancreatic or biliary ducts. Now one more examination for the biliary tree, that is MRCP, magnetic resonance cholangiopancreatography. It is a relatively new technique for being the bile duct, the pancreatic duct and the gallbladder. Unlike the other techniques mentioned here, no contrast medium has to be administered for MRCP. It uses only magnetic resonance to produce detailed images. Here is an image of MRCP. Now the difference of ERCP and MRCP. There is differences in imaging procedure. In ERCP, in this case, this is an invasive procedure that involves the insertion of an endoscope through the mouth into the duodenum to reach the bile ducts and pancreas. Once the endoscope is placed, a contrast dye is injected and X-rays are taken to visualize the ducts. And in this MRCP, this is a non-invasive procedure that uses magnetic resonance technology to produce detailed images of the bile duct and the pancreas, and no endoscope or contrast media is used in MRCP. There is different purpose for ERCP and MRCP. In ERCP, it is primarily used to diagnose and also to treat conditions that affect the bile duct and pancreas, such as gallstones, tumors, and blockages. During the procedure, the doctor can also take samples of tissue or fluid for further testing. And in this MRCP, it is primarily used for diagnostic purpose to evaluate the structure and function of the bile duct and pancreas. It can help diagnose conditions such as gallstones, inflammation, and tumors. And there is also risk and side effect for both. In ERCP, it's being an invasive procedure that carries the risk of complications such as bleeding, infection, and damage of the bile ducts or pancreas. Patients may also experience some discomfort or pain during the procedure and may require sedation also. And in MRCP, though it is a non-invasive procedure, it does not any risk of bleeding, but patients may experience some discomfort lying still for an extended period during the procedure. Here we may come in summary that ERCP is a non-invasive diagnostic and also a therapeutic procedure that involves an endoscope and X-rays, while MRCP is a non-invasive diagnostic procedure that uses MRI technology. Here we can see an endoscope passed through the stomach up to the duodenum, and there we can see some stones, and if doctor needed, they may do sphincterectomy and also remove the stones through ERCP procedure. Thank you so much. I am so thankful to our HOD and also our radiographers who encouraged me and guiding me to complete my project. Thank you so much.
We are all thankful to have your description, Deva.